welcome everybody this afternoon to the next Scale Neonatology Grand Round, currently in Norway. So I bring you Norwegian greetings as opposed to Ugandan greetings today. We have a fantastic lineup for you as always. We've got a team from Kawempe who will join us first, and then followed by a team from the UK. Today, the topic that we've chosen is preterm optimization. And I think we're going to hear from the presenters, but globally, the preterm mortality is the leading cause, not just of neonatal mortality, but mortality in under fives. And we know that around 60% of our preterms who die within the first 24 hours, at least in settings like ours in Uganda. So really, all of us on this call today, we're really taking a key step towards learning how to optimize the care, particularly around the time of birth, and help reduce not just the mortality, but the morbidities that come with these preterm babies. We're going to have the team from Uganda present first, and we'll follow that up with a presentation from the UK team. And finally, we'll leave that open to discussion. Our first presenters, we have got from Kawempe Regional Referral Hospital, Kawempe National Referral Hospital. We've got Dr. Wangala, and we've got Sister Juliet from Kawempe.
Thank you so much for this opportunity, and greeting to everyone. I'm Dr. Wangala Francis Xavier. I'm a pediatrician. I completed my PED residency from Makerere University, and I've been working with Kawempe from 2018. And together with me, I have Sister Juliet Nantaba, who is our in charge. This is the nurse in the special care unit, and she's also involved actively in the management of our preterms. So they are all welcome as we try to see how best we are going to learn about our preterm optimization, and we're trying to see how we bring about what's happening, the challenges that we are facing, and then also the recommendations. So for Kawempe National Referral Hospital, it's a super specialized hospital in Uganda, and it's located in Kampala. That's the capital city. So Kawempe is involved in management of both the obstetrics gynecology and also the Department of Pediatrics. And as you can see, in the Department of Obstetrics, we have the major clinical units where we have the oncology, we have antenatal, we have the fertility, adolescent clinic, the Urogyn. We also have emergency. We have a fully packed labor suite, and also where we deal with the gynae emergencies as well. So then in the Department of Pediatrics, that's why we also have major clinics. We have the special care unit as well. Our special care unit is divided into, we have 4 partitions, where we have the neonatal intensive care unit that receives those babies that are very critical. And then we also have the care preterm. We also we receive both the term and the preterm. And Kawempe, being a national referral, receives babies from all around the city and also around the neighboring districts. So all these babies are admitted. So we have those that are born from within the hospital, and we also have those that are referred from the neighboring facilities, as well as those that are delivered on the way or from home. So all those, we accept them in the unit. It's also important to note that we have HDU and also ICU, both for the adults and also for the children in those parameters. Also important to note is that when you try to see our catchment area, it's more in the central of the country. And then also important to note is that we have a capacity that can handle, we are supposed to have up to 60 beds in our special care unit. However, you find that because this is a place that receives babies from all regions, we tend to have it exceeding our target. So we have to improvise with the available resources to also cater for all these babies and the referrals in. So all these are just still what we provide. We also provide things like occupational therapy. We have our nutrition unit because we have a nutritionist who heads it. And then also we have those other days we have designated for our high-risk babies that we had in the unit, and maybe they spent long, or maybe they were very critical. So we have that bit of follow-up in our clinics. Our special care unit is the busiest in the country and Africa at large. As already highlighted, we have a monthly turnover of 700 neonates in the unit. And on average, they are about, we have between 80 to 130 neonates per day, which is way beyond our capacity to handle. So that's why we have to improvise. And of all these, about 90% are they are premature with low birth weight from 0.5 to 2.49 kilograms, which approximates about 40 to 60 preterm neonates. So that gives us a picture of exactly what's happening in Kawempe and the units that we are managing. So what one point to know is what preterm optimization is. So under preterm optimization, we use the definition that's from the British Association of the Perinatal Medicine, where we have this is an approach to care that concentrates on improving the preterm outcomes by reliably delivering evidence-based interventions in the antenatal, intrapartum, and also the neonatal period. So in the epidemiology, we try to want people to know what a preterm birth is. So preterm birth is a birth that we get before the 37 weeks of gestation. So they have to be completed. So we have around 1 in 10 births being preterm, and with a global prevalence of about 15 million preterms, which are the births we receive annually. However, in Uganda, the information we have is around 14 preterm births per 1,000 live births are registered. And also the preterm births account for about 8 of the 27 neonatal deaths per 1,000. So we also tend to report a high rate of home births, where we have 1 in 4 births outside the skilled care. That means that can be delivery at home or maybe in transit as they are heading to hospital or to any health care facility. Then also important to notice that only approximately about 50% of the babies, they have the chance to get the postnatal checks within the 48 hours. So this one gives us what would be the ideal preterm optimization pathway. Okay, so one thing which is important is for when you read with they developed a care pathway, the perinatal optimization care pathway. And this was tried to categorize into 3 aspects. So the first aspect tries to bring from predicting, you want to predict if we are going to have any preterm birth. So under the prediction here is where you tend to want to know, to have a detailed history. Okay, so when you have a detailed history, it is able to give us, for example, for the mother, a mother who has had a previous preterm birth is at high chance of having another preterm birth. So it's important for us when we dig in the history, we are able to tell that this is a mother at high risk or this mother is not at high risk. Then also During that, we can also check up the fetal fibronectin, which this one just helps us. It's an adhesive material that helps to have the fetal membrane, okay, that helps have our placenta adhering well to the uterus. So in case when we are going to have a preterm birth, so we tend to have some of this material getting out, being detected per vagina. So in case the pregnancy has not made 34 weeks and we tend to have some of this material, then that also gives us a picture that we are going to have a preterm birth or something already we're having the placenta peeling off from the what? From the uterus. Then as well as knowing about the cervical length. Then the other bit is the antepartum. We have the antenatal optimization as well as the prepartum optimization. So in the antenatal optimization, how we optimize here is once we know that a mother is expecting a very preterm or the very preterm baby, so we want to have this mother get delivery done from a tertiary hospital. So this is where we see that this is why we say that at least we have less of the mortalities if we have specialists working on these mothers. So for the mothers that we anticipate that, we advise them, if you are in a referring site, we advise these are the mothers you have to put at the first priority to refer to tertiary institutions. Then also here we emphasize the antenatal steroids. So the antenatal steroids are preferred to be given at least within the first 7 days, the 7 days before delivery, okay? Most preferably at least 24 hours before you have had the delivery. In case the mother received the antenatal steroids more than 7 days before they deliver, they can still give another shot. As we shall be seeing that all these have their advantages, which I try to highlight down according to the researches done. And then also important is the magnesium sulfate, which is also advised to be given to mothers where the gestation age is at 30 or below, and we're anticipating preterm birth. So since the magnesium sulfate was introduced, most in the areas Kawempe, we are doing that, we are giving them, and here it's majorly for neuroprotection. As the research gives us that we have about 30% reduction in the risk of cerebral palsy. Then for the other bit, the antibiotics. For the antibiotics, these are the intrapartum antibiotics. So when the mother starts having this prom or premature rupture of membranes, in cases of preterm birth, it's advisable to give antibiotics because our worry is usually for neonatal sepsis, where we have the complications of group B streptococcal. So most times we have to treat them, the mother, so that as they deliver the babies, we reduce that risk of early neonatal sepsis coming from the mother. Then the last bit, a third is the one of the prepartum optimization. So here what happens is there's what we call optimal code management. So here we are encouraging for our preterm babies that immediately after delivery, we can delay clamping the cord. So delayed clamping of the cord, they have seen it's more protective. It also reduces on the death and also reduces on the demand for future transfusion during the neonatal period. And also important to note is at least we advise it should be 60 seconds. Then the other bits would be the normal thermia, where we encourage the normal temperatures, where it should be about 36.5 to 37.5. So this should start way back from the delivery room, making sure that the place is closed, it is warm, and also organizing for the things you are going to use for receiving the baby. So the towels should also be warm, so that all this process, as you receive the baby, you finish drying and then you're receiving the warm towels. Then as well as you transfer to either the niche or the setting you have, where you also have the warmers that should be there already pre-warmed for these babies. Then the other thing also we highlight in this should be the maternal breast milk. So this one now, like for example, in Kawempe, we are encouraging early initiation of the breast milk for our preterms. So this is very important for them, as we shall see the advantages, and one of it is trying to help us reduce the incidences of what? Necrotizing enterocolitis. So this whole cycle, how the pathway should be in line with the parents, making sure that the parents are counseled and also they are also involved in the decision making. So this should be more of a cycle that is involving everyone that is managing the baby as well as the caretaker. The objectives of our preterm optimization. One, as we have seen from all this, we are trying to improve the neonatal outcomes, as we shall be seeing in the long run, and then also reduce the short and long-term complications which are associated with prematurity. And also important is also supporting the maternal health, and then finally having it as a multidisciplinary approach, as we have seen that the whole process will start from way back where the mother, from the obstetricians, and then as we also patch up and move in to the neonatologists, pediatricians, the nurses, not forgetting also the midwives who also help in the deliveries. So in the antenatal interventions, we have talked about most of them. It's just highlighting the key things about the antenatal corticosteroids. And for these ones, they have been very important, or we have seen it. Even the studies show that they help in lung maturity. For magnesium sulfate, we have seen that it's for neuroprotection, and the antibiotics, that's already highlighted. And then for torticollis, we encourage delay of labor for at least 48 hours to administer interventions. So we usually advise the people that the best transport media is the uterus. Okay, so if possible, as you are planning to refer this mother to a higher center, our aim is to, as much as possible, to ensure that this mother goes with the pregnancy up to the higher centers. So if there are any interventions, it's much, much better when there are specialists in the area. The delivery plan, so this is important. So the timing and mode of delivery based on the gestation age and the fetal condition. So as we had said, you plan what time to deliver, but in case it has happened and we see the center is not well equipped, we look for a better place or a higher place. We should maintain the sterile techniques to limit or to try to avoid neonatal sepsis. Okay, and for the lady cord clamping, that one I've elaborated more. And then also ensuring that the neonatal team is always present. There should be a neonatologist, we should have pediatricians, we should have the nurses, or everyone on board when we are optimizing. Okay, and this is under neonatal care optimization. We highlighted the thermoregulation, where we have immediate drying, and then also we also have what we call immediate kangaroo care, and also we have immediate and intermediate. So the immediate is working, and then however, when the mothers they are separated from the babies, when the babies are taken to special care unit, so you find that there's that gap. So here the babies are put in the warmers, as you can see there. We have our warmers, we have incubators, and then we also have mechanical vents in our neonatal care unit. And then it's also important to have these babies supported. When it comes to respiratory support, we have CPAP, we have the nasal problems. We also have surfactant for those that have respiratory distress syndrome. They are administered, they are given surfactant. Then we also have caffeine. All these molecules are being provided by the government, so the mothers don't have to pay, because for surfactant, it's a very expensive molecule and very few can afford. But we are privileged to have that being available in a public hospital. Then the nutrition support, as we have talked about, early initiation of breast milk. And then for the babies that are unable, maybe those that have developed necrotizing enterocolitis, the other option is having them on parenteral feeding. So under parenteral feeding, we are giving them neonatal cocktail mixture, and then we're also giving them the amino acids. Okay. Then when it comes to the infection prevention, yes, when it comes to infection prevention, we emphasize in hand hygiene. When you go to the unit, we do have a lot of areas for washing hands. We have now sanitizer. We were putting alcohol on each bed. We have at least a point, so that we try to limit the spread of infection from one baby to another. And then the other thing we are having is uh, the mothers, we give them the aprons to come in when they are coming to see the babies, so that they don't have to come with the dirty heavy clothing from the outside and then coming to contaminate the area. So that's the other bit we try to limit. And also maybe what is also important is we try also, because we have numbers which are more than our capacity, so we try to nest the babies so that they are separated from each other, also to help us to limit contact from one baby to another. So what are the challenges we are facing? Challenges in the preterm optimization. So importantly is access to trained personnel and NICU facilities. So in Uganda, there are very few NICU facilities that are well equipped. At least for Kawempe, we are lucky to have three vents which are now functional, with others not functional. We have a few neonatologists in the country, so you find that this is hindering care for those that are deep in the villages or are away from these facilities, those who can't afford Kawempe. And that one also explains why we have the too much load, too much, we have a high rate of referrals in the unit because of these few specialized personnel that we have. Then the other bit is the limited staffing, especially the nursing team, where you find that at times you have to find that a niche which has like 10 beds, you are finding 1 to 2 nurses who have to make sure that all these babies are cared for. So it's a very big challenge. And then also having a limited number of equipment. So on top of having our CPAP machines, equipments, and also the vents, we reach an extent where we have few compared to the big numbers we have. So it becomes a very big challenge. And then also the other challenge is there's a lack of proper documentation of interventions done. For example, when mothers deliver, you find that in their records of antenatal, you don't know how many doses of antenatal steroids they have received. That is not clear in the system. And you remember they have been referred in. So all the things are not well documented, whether they received antibiotics. So it becomes a challenge. And then the other challenge is continuity of care after discharge. So because most of them they are coming as referrals in. So after discharge, they tend to prefer to go back to their areas that they came from. And remember, these areas, most of them don't have the good care for the preterms. So you find that there is a problem with the continuity after discharge. Others, even when they are given follow-up days, it becomes hard for them because of the costs coming back to Kawempe. So it becomes a challenge on top of us having 2 days designated for the preterms. Okay. Then the other bit is also in the study done by Nalwada et al. There was lack of information, and there was also mismatch between the community expectation and the reality of care at home. So, of course, apart from the stigma and all that, then this is just a summary of the key interventions that we have in place. So the government of Uganda, together with the Ministry of Health, they have set up more NICU, those are neonatal intensive care units. So they are trying to expand from not only Kawempe, but also the plan is to have also other regional referrals, the surrounding regional referrals around the area, to at least have these NICU services and also have the neonatologists there. And then also the government has also come up with the treatment guidelines, okay, when to give surfactant and then caffeine. Then also there have been training sessions. We have had people from different areas coming to Kawempe to learn, to know how we are doing things. And then also, as I mentioned it earlier, I find that Kawempe is privileged to be having a good supply of surfactant. and also caffeine. So on top of that, the CMEs are ongoing. So all these are helping us to have higher survival rates. Then for the antenatal, the key strategy is to have early booking. We have our antenatal care unit that we have tried to equip, and at least we advise the mothers to come for the visits that they have been scheduled for. And this also has helped us to reduce on the delivery complications and also improving our survival. Then for the facility-based, we have improved the specialized neonatal care with quality improvement. We usually have an audit that is every week on Monday to see where the gaps are. If there are any babies that died, what would we have done better? So that comes out in those meetings. Okay, and this has helped to improve greatly the mortality rates to go down. Then the parental support. There has been education and the psychological support. We have partners, for example, the Preterm Infants Parents Network Uganda. It usually comes in and helps these mothers. So as when they are being discharged, we tend to have them also incorporated to receive their services. Okay. Then the post-discharge and follow-ups, we have the parent groups, and then also we have the clinics that help us. That help us to review these babies as they grow and also monitoring their growth. So in our long-term follow-up, we tend to monitor for the neurodevelopmental outcomes. We have a clinic which helps us in doing a screening for retinopathy of prematurity, and also we also do the hearing screening as well. Among also the other services we provide, we have supportive therapies like physiotherapy, occupational therapy, and speech and language therapy, especially for those that have had a mental impairment, for those that have been affected by cerebral palsy. So this is also another clinic that moves on, that is also ongoing from Monday to Friday. So in conclusion, preterm optimization saves lives and also improves the impairment-free survival, and also importantly is also it requires early intervention and coordinated care, as we have seen. And also we have to also have the ongoing research and policy support, because these are very critical. And then not forgetting that preterm birth is the leading cause of neonatal and childhood mortality in our country, Uganda. And then we have also to know that a mix of antenatal care, strengthening of specialized neonatal care, parental support, and community systems can help optimize the outcomes. Then also very important is the collaboration, and this has helped us a lot between the government and the NGOs, also involving also the health workers and the parents as well. This has helped us in the long run of also getting finances and support to run the unit as well. Then maybe our recommendations, this will be my last part of the presentation. So we had a gap in the antenatal documentation. So ensuring proper documentation for antenatal records is very key here. And then also booking these mothers. We believe when they attend antenatal care clinics, there is a very big difference in the outcome. And then also expanding the quality focused interventions, like having a childbirth checklist, and also pronto training where we have simulation exercises and people can learn from that. Then investing in infrastructure and staff training, especially for specialized neonatal care across the regional facilities. So this is very important. This will also help us to limit on the numbers that are referred to Kawempe. Okay, then support community-based initiatives like those parents networks, and also important is having the milk donor programs for the mothers who are unable to produce their own milk. And then also strengthening the post-discharge systems. This involves, for those that cannot make it, at least we can have the phone calls or messaging, and then also follow up, also helping them also you link them up to the nearby facilities. Okay. Then finally, the tackle for the developmental risks. So this one involves it's important to screen for malnutrition, screening also helping us there. I think which is missing here is we do also the checks. We said we have an ophthalmologist who comes to do the screening for you want to do for retinopathy of prematurity, and then also immunization. You have to ensure that these babies are immunized so that they don't get those preventable diseases as they grow, and also ensuring that the caregiver support programs are enhanced. So those are our recommendations that we think would be very key. Then, and these were the references.
Amazing. Thank you, Dr. Wangala. That was fantastic and incredibly comprehensive. We're going to move on to Sister Juliet Nantaba now.
Okay, thank you so much, Kathy. Thank you so much, Dr. Francis. Good afternoon to everyone. I'm going to take you through the nursing care in preterm optimization. Those are some of the pictorials that speak what is done in the newborn care unit. Introduction. Not all babies are born ready for the world. Some arrive too soon, fragile, and fighting for every breath. In the neonatal unit, we meet these tiny warriors, often small enough to fit in the palm of a hand, yet carrying the strength of giants. Therefore, preterm babies require specialized care to thrive. As nurses, we play a vital role in providing compassionate, evidence-based care to support their growth and development. The major challenges, we know that there is extrauterine stress for these preterm babies after birth. So these are some of the challenges they face when they are extrauterine, one of which is hypothermia, hypoglycemia, infections, hyperbilirubinemia, respiratory distress syndrome, feeding difficulties, apnea of prematurity, intraventricular hemorrhage, metabolic acidosis, retinopathy of prematurity, and anemia. So these are some of the things that we look out for in terms of optimizing care in preterms. So long as you know what the challenges are extrauterine, you're able to provide the adequate care. So one, in the nursing care, we provide optimal management at birth. This is by providing promptly dry and keep the baby warm with gentle handling. Initiate uninterrupted skin to skin as soon as possible. Examine the baby fully because we anticipate that these babies could be having some abnormalities that are external, and give routine medications such as vitamin K and tetracycline eye ointment. Then also administer oxygen therapy to maintain oxygen saturations of 90 to 95%. And then the preferably mode of delivery for oxygen should be CPAP when it is indicated, then after which we transfer the baby to the neonatal intensive care unit. Then when we come to maintaining breathing, this starts immediately after birth. We understand that first nursing intervention in the first 5 minutes of life determines a lot in the outcome of the preterm baby. Therefore, we have to make sure that we utilize the skill and knowledge that we have when we are providing care for these preterm babies. So you ensure airway clearance and proper positioning for this preterm baby. Then you initiate oxygen therapy to maintain the oxygen saturations of 90 to 95%. And then let's say the baby is admitted in the neonatal unit, we continue with the oxygen and or a CPAP if it is indicated. While in the NICU, we also make sure that we take note of the interface for the CPAPs and then the nozzle prongs to ensure they are fitting in both nostrils. And then we also ensure that the bubbling chambers for the CPAPs are really functional. We also ensure availability of adequate oxygen from the source, and then also to suction when needed to maintain patterns of airway. Continuation for breathing, we do assess for the need of mechanical ventilatory support if available. Some of the signs are apneas, respiratory distress syndrome. And then for the babies who are intubated, we make sure to suction through the ETT and monitor the vital signs closely to rule out blockage of the ETT. And then we adjust the FiO2 to maintain oxygen saturations of 90 to 95% to reduce the risks of retinopathy of prematurity. We ensure zero separation I'm providing the nursing care that is actually practiced in Kawempe. So we must focus on zero separation between mothers and their preterm babies. Also to involve the parents in the care of their preterm babies from birth, because this provides a better outcome when the patient, the attendants are well informed of what is going around with their babies. The goal is to improve quality of care and outcomes of the baby, also focusing on keeping the preterm infant with the mother, even in the neonatal unit. Prevention of hypothermia. Hypothermia can be due to the ineffective thermoregulation center in the underdeveloped brain. Therefore, it is important for a nurse to provide optimal temperature immediately after delivery. Immediate kangaroo mother care has been shown to reduce mortality by 25%, and when possible, should be initiated, except if it is contraindicated according to the baby's condition. For the extreme low birth weight, consider using plastic bags to aid thermoregulation. Continuation for prevention of hypothermia. Other equipment such as incubators and radiant warmers can also effectively keep babies warm, keep the baby nested when not in kangaroo care, delay bathing, encourage and promote effective skin to skin, then minimize heat loss during procedures. Then we also have another role of preventing infection, since our babies are at more of a risk of getting infection. So hospital-associated infections, or the highs, are a key challenge in preterm infants. We must maintain strict hand hygiene before and after handling the baby. We also have to undertake only minimal handling, thereby limiting the number of attendants and caregivers so that we don't have more of much handling to these babies. Then we also ensure to use sterile or aseptic techniques during procedures, and also to monitor for early signs of infection such as temperature instability, lethargy, or feeding difficulties. Continuation on prevention of infection. We should also minimize invasive procedures to reduce infection risk. Routine practices such as changing cannulas and feeding tubes. Also to ensure clean environment and ensure appropriate equipment reprocessing for reusable equipment, and also to practice barrier nursing to prevent cross-infections. Prevent and control pain. Like anyone else, preterm babies feel pain too. They can present with the following signs. They can cry, they can have a tachycardia, they can have irritability and respiratory distress. So usually preterm babies do speak to us more than anyone else. So when you realize maybe some of those signs that have been listed above, you have to really find out what the problem for this baby is. So how do we ensure we prevent and control pain? We should ensure that we loosely secure the cannulas, nasal prongs, and the sensors. Then we do minimize pricks, change of position 2 hourly for the babies, and also administer analgesics when indicated. Monitoring is one other nursing care in preterm optimization. We monitor for vital signs, which are respiration, pulse, blood pressure, and others. Then we also have to ensure we monitor the feeding tubes, the nasal prongs, the nasal cannula size, because there are times you realize the cannulas are nasal cannulas are out, or the cannulation site is tissued. So we have to make sure we monitor this all the time so that we prevent risks of pain and also babies deteriorating without your notice. Then you also have to monitor for activity and behavior, because these babies tend to, speak while they are showing us. You monitor if there are any convulsions, is the baby lethargic or something, so that you know what to do for this baby timely. Then we also monitor for the color, because we are anticipating a risk of hyperbilirubinemia, like we saw. It's one of the challenges. So you monitor for whether the baby's color is pink, which is normal, and if there is any pallor or blue color or gray or yellow, then you intervene accordingly, because a baby that is yellow, it indicates that this baby could be having hyperbilirubinemia, or what we call jaundice. And then a blue baby or a pale baby can be due to anemia or signs of cyanosis. Then we also have to look at the tissue perfusion for signs of shock. And then also the breathing, if there are any irregular breathing patterns, so that you can intervene. Maybe there's airway blockage, or maybe the patient is in distress. Then also monitoring the weight, so that you know whether the baby is gaining weight or the baby is losing weight, so that you can look out for the pediatrician to take note of that. Then also feeding tolerance, monitor for whether the baby is vomiting, abdominal distension, gastric residuals. Development, minimal and supportive handling to minimize stress, then also to introduce touch slowly, always to contain the baby by swaddling or nesting to maintain flexed position. Then we also have to do regular positioning. We can do that from prone, lateral position, left or right, or even spine. Then we have to ensure we optimize nutrition, protect the skin, change of napkins, and change of position. Then we have to ensure to take note of the healing environment, control noise, light, temperature, and touch. Nutrition and feeding. Baby should start intravenous fluids according to day of life when admitted to the neonatal unit. Early initiation of breast milk, monitor weight gain and nutritional intake, support mothers with lactation, ideally with a breastfeeding specialist or trained nurses. Then also to consider fortification of breast milk if necessary and available. We also have to monitor for feeding intolerance by observing for vomiting, abdominal distension, change in color of gastric content, or change in bowel movement. Medical management, give prescribed medications such as antibiotics and caffeine citrate, vitamin K, and then document appropriately. Ensure to administer the right drug, right dose, right route to the right baby at the right time. Monitor side effects and adverse effects of the drugs. Monitor and regulate the continuous neonatal fluid infusions. Teach family and encourage family involvement. Educate parents about preterm care, feeding techniques, and recognizing warning signs. Involve parents in care routines to build confidence and strengthen bonding. Provide emotional support and access to counseling services for coping with stress. Also, encourage follow-up care to ensure continued growth and development after discharge, and also teach about immunization and danger signs in these babies. Thank you so much.
Juliet, thank you very much for a fantastic presentation. Beautiful photos to illustrate your points as well. So thank you for sharing those with everyone on the call. So both for Sister Juliet and Dr. Wanjara, let's show our appreciation in the chat for their wonderful presentation. Dr. Kath and myself, we're trying to answer questions in the chat as we go through, and we will continue to do so. If we have time at the end, we will go through outstanding questions or open up for discussion. I would like to hand over to our UK team today. That's Dr. Pamela Ohadike and Sister Blaine, who are going to share their experience of preterm optimization from a UK perspective. So I'm not sure who's sharing slides, if it's Janetta or Pamela, or if it's you, but please go ahead. You're most welcome.
We've had an excellent presentation, which has already gone through a lot of what I'm going to say. I work in a level 2 unit. We have 3 levels of neonatal units in the UK. So as a level 2 unit, we take a gestation of 27 weeks and above and 800 grams and above. And if a baby presented or a mother in labor and was of a lower gestation, we'll try and transfer them out to another hospital. we've seen this chart, so I'm going to stick to this chart itself. So with us, in terms of our antenatal bits, we have neonatal alerts, so that if there's a woman who is likely to be delivered early for any particular reason, this alert goes to the neonatal team, and a joint plan is made as to where to deliver the woman in the right place and at the right time. I leave the rest about the fibronectin and cervical length to the maternity team, but the important thing is that we work closely with the maternity team so that the parents remain informed and they also feel involved in the decision making. So every day, a member, a consultant, and the head nurse will go from the neonatal unit over to the labor ward, have a chat about what babies they have and what's happening, and whether anybody needs to be transferred sooner rather than later, instead of leaving it too late so that baby happens to be born in the wrong place, and thereby reducing its survival or increasing its morbidity. And also meeting the parents also helps you plan for delivery as well, so you can get more information, check over the mother's notes, find out whether there's infection or anything else that someone has forgotten to mention to you. And often at delivery, it's too chaotic to get all that information. We also get the parents to visit the neonatal unit so they know what to expect, because it's quite daunting with all the machinery and the drips and the lines. So they come and have a visit on the neonatal unit as well. So there are 7 steps, as we've heard, so I'm not going to go through them again. These are the different aims of the toolkit. And as I've mentioned, they're identified properly, transferred if necessary. They receive a full course of steroids. So we've had a major project to try and improve our numbers, because we get data. Every neonatal unit gets data. So increasing the education and knowledge of both midwives and the neonatal team about giving the steroids, and the obstetric team, and our figures have gone up. All women who are born before 30 get magnesium sulfate, and all this data is captured on our electronic system when they're admitted. And they should also have prophylactic antibiotics for group B streptococcal infection, whether they rupture their membranes or not. And this is the bit I mentioned about singletons less than 27, or twins and above less than 28, and less than 800 should be delivered in intensive care units, which we call a level 3 unit here. And they can do things like oscillation, give nitric oxide, and do more complex management. When we first initiated delayed cord clamping, it was a bit chaotic, but we now have a good system. We have a special platform that we can even use in the theatre. So even if the mom's having a section, we can put it beside the bed, and the baby is placed on mom's legs, and whoever's at the resuscitator can do the counting and will then inform the obstetric team that it's a minute, and then they clamp the umbilical cord, unless there are specific contraindications to that. And it's shown that it prevents the death overall in babies. Normothermia has also been spoken about. So we use the overhead heater on the resuscitator, and sometimes we have to use the exothermic mattress to place them on. So this is just to remind us about the different ways heat is lost from the baby. So evaporation. So if they're a younger gestation, you put them in the plastic bag, put on a hat. An older child, you would wipe them promptly. The transwarm and exothermic will help with conduction. Convection, making sure your theaters are the right temperature. You probably won't have as much of an issue in Uganda, but our theaters are often too cold here, and we have to remind them to turn them down. And then radiation, we have the heater on top of the resuscitator. This is just to go through the optimal cord management. I won't go through it more, but this is what we had to work through so as to get a good process in place. So we've mentioned parents as equal partners in their care. So even discussing things like giving vitamin K at delivery, whether the mom's going to breastfeed, and having a birth plan, that's all done antenatally. They have antenatal education. We teach them about early expressing of breast milk and tell them, and the way we sell it is that colostrum is like a medicine, more like a medicine, because even if they haven't come, their milk hasn't come in, if we can at least get the colostrum in these preterm babies, that's very useful. So we ask them to express soon after birth, and Anne will go through a bit with that. And we try and give this within 6 hours of birth. At delivery, we try and encourage physical contact, even if they're ventilated. The mother gets to have skin to skin before we transfer the baby to the neonatal unit. The second part is about sustaining lactation and breastfeeding. As I've said before, parents are equal partners. Even dads have kangaroo care, initiation of expression, which I mentioned, and Anne will go through a bit more about this later on. So I've got a case presentation. We had a mom who had essential hypertension, but she wasn't on medication, and then she developed PET on top of that. She had labetalol, and I put the things in red that went well. She had 2 doses of steroid, 1 lot of magnesium sulfate infusion, and she'd had antenatal counseling by the neonatal team. The baby was born by section, put into a plastic bag. The baby initially cried, then went bradycardic, so the cord wasn't clamped for a full minute, and the baby was transferred to the resuscitator. All the SATS probes and hat was put on, and while on the resuscitator, the baby started crying again. APGAR at 1 minute was 8, SATS were 50% in air, but we had a good heart rate. Temperature was a little bit low, and this improved, and at 10 minutes, we had good APGAR, SATS were 95 and 30%, and baby was getting some PEEP. We put a transwarmer under the baby to help warm the baby up, and a repeat temperature was 36.8 with a heart rate of 157. Mom managed to have cuddles, and we actually managed to give colostrum, buccal colostrum to the baby. So that means just putting the colostrum inside the cheek of the baby's mouth. On the second day, the baby had some aspirates, bilious aspirates, so had triple antibiotics, and these are the antibiotics that we use here. And this was for possible necrotizing enterocolitis. Mom managed to successfully produce more milk, and by day 15, baby was on full expressed mom's milk. Baby had high flow, which is vapotherm, until day 29, and is currently on low flow oxygen. So I'll let Anne continue.
Hi everyone. The colostrum packs we give sometimes at birth, or we give them to dads if he comes round with baby and they go back to the mom. And the woolly squares on the left-hand side are what we use as what's called bonding squares, and we just pass them between mom, dad and baby, just so that they feel a closeness to the baby, and moms feel that there's something of theirs close to their baby. We have the syringes to catch the colostrum, and then a breast milk expressing journal so moms can so that moms can remember when they expressed, how much they're doing, how well they're doing, and it's up to the nurses really to ensure mom is getting the support to do that, to liaise with the maternity team, see how mom's getting on. Sometimes dad help with the expressing if mom's too tired or unwell. So we just keep that contact with maternity. Some mums can come down quite early to see their babies, so we try and get them involved as much as possible, and expressing them, because mums are wondering what they can do or what dad can do, and the expressing is the most important thing. So mum wants to get the milk, even if mum's chosen to bottle feed, most of the time she will get at least some of the breast milk, and go on to breastfeed possibly. Anyway, so we get them to express the milk, and we ask them to do it at least sort of 8 to 10 times in 24 hours, and it can be done at any time, and not to leave it longer than 6 hours at night or 4 in the day, and try and emphasize how crucial this colostrum is for the baby. And because they really want to be doing something and getting involved, then it's normally really well received. And dads like to get involved too, make sure mom's comfortable, and they may help with the expressing. We have something called a Badger Diary, which is they download the app, and we can keep contact If mum's discharged or up on the ward or unable to come down, then we send videos and pictures to mum and dad. So that's really well received. With regards to nappy cares and things like that, we encourage developmental care so that it's an individual basis. So when babies are awake, then we will do the nappy cares. We get mums and dads involved as much as possible as they're able, especially in the days shortly after birth. So they're all quite keen to get involved. And we train dads to get the babies out for mum to hold in skin to skin. So it's all, we're sort of training parents to help look after their little ones. So it is a joint effort. They're involved with the ward rounds, and they can give an update to the doctors of their sort of antenatal, perinatal history. We do as well use the breast milk fortifier if babies are on 100 mils per kg of milk. I think that's it really. Oh yes, we have a milk warmer. We're fortunate enough to have the milk warmer, and parents have access to the milk kitchen, so they can get involved with making up their own feeds, warming their milk up, defrosting their own breast milk. It's all coded, so their milk is individual boxes.
So these are just the things we've put on the walls just to encourage people's knowledge about expressing, and the checklist. You can read that for yourself. So it's about antenatal, skin to skin, and these are just the things to encourage breast milk, which is best for the baby. In terms of our mortality rates, it's 2.9 per thousand now in the UK, and it's quite old data. That's the latest data that we have. And that's the end of my presentation.
Thank you, Pamela and Anne. That's really great. For me personally, super excited about the colostrum packs. I've seen them here in Norway, but I don't think any of us in Uganda have branched out into colostrum packs. But the idea, I think you've on the last slide of the QI project for all of us with colostrum would be a great one for many of us on this call. The earlier we start expressing milk, the more likely our babies are to achieve successful express breast feeding up to 6 months of age and beyond. So I think we can all take something away from that. So appreciation to Dr. Kath Harrison as well in the chat. She's been trying to answer as many questions as possible. And I don't know, we have got a little bit of time remaining. So if anybody wants to put another question in the chat, or have any questions directly to either Francis and Juliet or Pamela and Anne, then please go ahead, type them in the chat or raise your hand. Otherwise, huge appreciation to all 4 presenters this afternoon. It's been really insightful.
Someone's asked about transfusion in a preterm.
Yeah, do you want to take that, Pamela?
So we have a guideline, and it depends on how old the baby is and whether they're on oxygen or not. So probably between 7 and 8.5, but it would depend on how old the baby is.
Yeah, thanks, Pamela. I forget what's in the national guidelines. I did share them in the chat, the protocols for care of the small and sick newborn that were published in Uganda 2023. And I think Jeanette's going to send those out on email to the mailing list. I think typically in Uganda, less than 10 for babies on oxygen or CPAP, and less than 8 for those who are not. Dr. Jessica, you have your hand up. Please go ahead.
To the UK team, I'm a neonatologist based at one of the national referral hospitals, where we dig in every day with the preterms, and typically it's the story you have heard. So now my question to the team from UK is, looking back from your experiences, maybe personal or professional, what are those lessons you've learned or experiences you had then that looking forward, you believe you could have done better, you could have known better? Because we are still somewhere in Uganda, I think you've heard from our different perspectives what's actually going on. And from you, I want to just 1 or 2 maybe experiences that you have looked back in hindsight and felt, oh, we should, have, done ABC earlier or known this before. As you see, neonatology has this pitfall history with so many things we've learned from. far away from the oxygen, toxicity in the 60s, Stevie Wonder being blind, coming forward, the CPAP chamber, then the oxygen chamber, then forward. We used to clamp the cord quickly. Looking back then for you, and I think it may not be fair to ask this question. You could speak from where you are, not the general country semantics, but from the UK angle, what are these lessons you believe we could also learn from going forward to improve our neonatal care and health and outcomes for our babies? We have all this knowledge. We improvise here and there.
I think
we have the preterms, we have the babies, but what are those specific things we need to feel?
I think as a neonatologist, simple things like colostrum. You know, we get impatient and you focus on the weight gain and you focus on getting milk into a baby. And I think learning to be patient and learning to encourage moms to breastfeed is something I think that's done well now. And Anne has another thing to talk about.
It's as developmental care lead in the past, working alongside the feeding team, it's skin to skin, parents interaction, the importance of the milk, like brain protection of the brain, de-stressing. It's just all linked up together, developmental care and getting the colostrum especially. And yeah, it's more individualized care, I think, that I've learned over the years, rather than doing things by the hour, or, you know, you do it when they're awake, changing the nappies when they're awake, rather than doing it because it's due at 2 o'clock. Just wait till 2:30, or, you know, if they're awake at 1:45, then start then, rather than wait till 2 o'clock. But developmental care and infant feeding is linked, and it's so crucial for these preterm brains and optimum developmental care.
Great, thanks, Anne. That's really helpful. I mean, I think actually probably Uganda we're at the forefront of kangaroo care, and actually probably we could teach the guys in the UK a thing or two, but really keeping, I think Juliet had her slide on zero separation, keeping these babies and mothers together. The mothers provide the developmental support, the developmental care, the breast milk, the love, the stimulation. I think that is probably is key, and I think high income settings are learning that now as well. And I think that we should also be proud of the way that we provide our neonatal care in Uganda, because I think there's a lot that can be learned from that. Dr. Loy, you've got your hand up as well. Please go ahead and ask your question.
Thank you very much, presenters from Kawempe, Dr. Wangala, Dr. Juliet, and the other teams from the UK. I'm Loy, I'm a neonatologist. Actually, I work with Dr. Wangala and Dr. Julie. Yeah, I had some engagement, so that's why I logged on late. My question is about the colostrum. I'm really interested in the colostrum. You flashed a slide that showed bags of colostrum. And I was wondering, how do you happen to get all this much colostrum? Is it mom's own colostrum? Is it colostrum that you've got from other moms and you're actually storing as donor colostrum? Because I think for us in Uganda, one of the things, and at Kawempe in particular, that we are grappling with is there's a lot of stress in these mothers, especially of the preterm babies, and that are so small. And at some point, they completely have no breast milk. And yet I know feeding, nutrition is one of the things that we should really be working on to optimize if we are to come up with good outcomes for these preterm units. I also appreciate the very serious and big importance of colostrum. But as a country, I think for the preterms, that's one thing we're not harnessing. Because the moment the babies are preterm, they come to the neonatal unit, the parents are scared. You're considering feeding on day 3 when you've already lost the colostrum. So I really want to know how you're making optimal gains and how you're able to have this colostrum. Thank you. And then there's a slide about NEC on day 1 in a preterm. I was wondering, I know it can happen, but was it really NEC? baby did not really have that marked perinatal asphyxia. They were preterm. Yes, thank you otherwise for this very informative presentation.
Wondered if Anne could speak a little bit to where you get the colostrum from and the utility of those colostrum packs. I think it's very novel to Uganda. It wasn't quite clear from the slide what the syringes are used for and where the colostrum comes from. I.e., is it donor colostrum or is it from the mother herself, and how do you get that colostrum from the mother? And then the second question, the baby is a preterm and was diagnosed with NEC on day 1 or day 2, which would be more in keeping with a term baby with NEC from asphyxia as opposed to a preterm, and why did you make that diagnosis? Were the 2 questions for you guys.
The colostrum pack is for mom, whether either if dad takes it back to mom or maternity, the midwife will take it back to mom, and so she can sit, relax and start doing some hand massage, and she collects the colostrum in the syringe, and then dad or the midwife will bring it straight down to us to give to baby buccally in the cheeks. So the packs are, the syringes are either popped in the fridge or ideally they're brought straight to us. And even if babies are nil by mouth, they can still have mom's milk in the mouth because it's absorbed before it touches the tummy. So, but it's just so crucial to line the mouth and the digestive tubes. The answer to your other questions, sorry.
Why we diagnose necrotizing enterocolitis? We just
more prophylactic, wasn't it, really?
Yeah, well, it was probable because and you can occasionally have it in preterms. It's not that you can't. And we definitely had bilious aspirates, abdominal distension, and I think the CRP went up as well.
And we'd still give mom's milk as mouth care just to keep the antibodies and everything to help fight any infection.
That's great. Thank you. I mean, I think for everybody, if you've got a bile and the picture is not clear in your baby, you need to consider other things. I think often we jump to conclusions, at least I've seen a number of times, we jump to conclusion there's a preterm and it's got bilious aspirate and therefore it must be NEC, but actually you treat for NEC and you delay and actually you find out you've got duodenal atresia or something like that. So I think the lesson here is that it's good to have a differential diagnosis and think about other things. Just trying to juggle hands and chat.
We did have a chest x-ray that showed the sentinel loop, a loop that just didn't change, the pattern didn't change, but the baby had passed stool.
Great. So that would help to differentiate between an atresia and a necrotizing enterocolitis, but we just need to take those things into account. So there's a lot of appreciation in the chat for both lots of presentations. One of the questions I think is interesting is about preterms who are aspirating after breastfeeding, and I think both myself and Anne have responded, you know, they need to have a safe suck and swallow, and different babies, irrelevant sometimes of their gestational age, they're just not able to coordinate that suck and swallow effectively. When do they develop suck and swallow? Between about 32 to 34 weeks, but every baby is different. So if they're not able to coordinate that and they're not able to move on to spoon feeding or they're not able to move on to breastfeeding, then just go with the baby. In like the UK, you would have a speech and language therapist that could help you with that assessment. But I think for us in Uganda, you can just observe, and if really the baby's struggling, let's encourage them or let's support them in other ways of feeding rather than jumping straight to breastfeeding. We've talked about NEC. Yeah, oh, that's interesting from Kath. So Kath, Dr. Kath Harrison has said colostrum, EB and mouth care can be kept going even if NEC is being considered. I didn't know that, Kath, and your microphone is not working. Pamela, could you talk something to that?
Yeah, Anne just mentioned that. So Anne just said that.
It's absorbed before
so it's absorbed through the buccal mucosa before it goes down. So you can still carry on with mouth care with the colostrum.
And so from a practical point of view, for those on the call, is that like 1 ml in the buccal membrane, or?
It's not really, it's just sort of, you wouldn't give too much anyway, just enough to, like you would with mouth care, just to clean the mouth, but you'd be using mom's milk instead. We wouldn't measure it, you just give
lollipop stick.
Yes, we've started using swabs, but because we did lose some of it in the, like we used to use this soft sponge stick. But we tend to just squeeze the syringe very carefully. It's less than 0.1. It's very small amounts. We just want to, so you are putting some milk into baby's mouth. We wouldn't want to give too much so the baby would choke, but it's just a tiny amount just to coat the skin of the mouth, really, like you would do with mouth care and a bit of sterile water. But we prefer mum's milk.
Great. Maybe I'll ask a practical question on behalf of the Ugandan team. We don't have special swabs and sponges and things. If we've got hypoglycemia and no IV cannula, we'd use a gloved finger and some gauze on the bottom.
Yes, you could do that as well. Oh, sorry. Yes, you could do that as well. Sorry. Yeah.
Okay, great. So I think we've all learned something, myself included, which is fantastic. Gloved finger, fine. Amazing. I think then from my side, I will once again appreciate all of our presenters today, Dr. Wanjara, Sister Juliet, Dr. Pamela and Sister Anne for the time taken to prepare and deliver these fascinating presentations so that we can all learn together. Appreciation to Scale Neonatology for making this possible and that ongoing partnership between the UK NHS through Health Education, NHS England and Uganda Ministry of Health. And I just encourage all of you to attend our next clinical grand round. We will communicate the topic closer to the time. I will be in touch with various people, as will Kath, to organize the presenters, but our next presentation is due on Friday, the 14th of November.